Good morning. Today I'll speak about adrenal paracrine factors, which are in fact regulatory factors that are released within the adrenal gland, and their potential as promising targets for new pharmacological treatments of corticosteroid excess. So I'll start with some classical observations. Primary adrenal hypercortisolism is due to unilateral tumors, or more rarely to bilateral hyperplasias, which secrete high amounts of cortisol. And in return, the increase in cortisol levels suppresses pituitary secretion of ACTH. In the same way, primary aldosteronism is characterized by an increase in aldosterone secretion, in half of cases by unilateral adenomas, which inhibit the activity of the renin-angiotensin system. And in these two situations, these tumors and hyperplasias maintain a high secretory activity despite suppression of ACTH and angiotensin II. So the question is, how does it work? In other words, is corticosteroid secretion autonomous, or is it driven by regulatory mechanisms that are independent of angiotensin II and ACTH? Genetic studies have shown during the recent past years that aldosterone-producing adenomas carry somatic mutations that activate the calcium signaling pathway, which is the second messenger of angiotensin II, and consequently stimulate aldosterone secretion by mimicking the effect of angiotensin II. In the same way, mutations that activate the CMP-PK pathway, which is the second messenger of ACTH, have been reported in tumors and hyperplasia responsible for Cushing syndrome. So these genetic events confer some autonomy to steroid secretion towards angiotensin II and ACTH. But the situation is more complex because we now know that steroid secretion can be regulated by intraadrenal regulatory factors in these lesions that produce excessive amounts of corticosteroid. Now I will focus on primary Cushing syndrome related to bilateral adrenal hyperplasias, and in particular to macronodular hyperplasias. We know that in these in these hyperplasias, cortisol secretion is regulated, as shown here, by numerous signals that are released by several cell types that are present in the adrenal cortex, such as chromaffin cells, adipocytes, endothelial cells, nerve terms, and sometimes steroidogenic cells themselves. These local mechanisms do exist in the normal adrenal, but they are enhanced in that the production of regulatory factors is enhanced and their receptors are overexpressed in comparison with normal adrenals, so that they are likely to play a significant role in the pathogenesis of cortisol excess. And to illustrate this concept, I will first focus on the role of serotonin, 5-HT, in a rare cause of Cushing syndrome, which is micronodular adrenal hyperplasia, especially primary pigmented nodular adrenocortical disease, PPNED. Now, it's known that in the majority of patients with PPNED, the disease is due to mutations that affect the PRKR1A gene, resulting in constitutive activity of pKa. And what we have shown is that increased activity of PPA results in upregulation of the serotonin signaling pathway. In fact, as you can see here, some adrenocortical cells in PPNED tissues produce 5-HT through expression of tryptophan hydroxylase, and also overexpress 3 types of 5-HT receptors, which are the types 4, 6, and 7. So the genetic defect that causes the disease induces the formation of a complete serotonergic regulatory loop, which is involved in cortisol hypersecretion. The second example I'd like to show you today is the ectopic expression of ACTH in another type of adrenal hyperplasia, which is bilateral macronodular adrenal hyperplasia. We had the opportunity to show that in a series of macronodular hyperplasias, some cells, some adrenocortical cells, abnormally express ACTH. And this seems to result from gonadal-like differentiation. As expected, ACTH stimulates cortisol in a paracrine fashion. In fact, as you can see here, plasma cortisol level in the patients is positively correlated with the POM-C mRNA levels and the ACTH immunoreactivity scores in the tissues. And most importantly, incubation of hyperplasia samples with antagonist of the ACTH receptor induce a strong decrease in cortisol secretion as shown here. So from all these experiments, we can conclude that cortisol secretion is controlled by intraadrenal ACTH in primary bilateral macronodular adrenal hyperplasias. And so to conclude, I will list some take-home messages. The first one is that corticosteroid production is regulated by illicit intraadrenal paracrine mechanisms in several types of adrenal hyperplasias and tumors, which are responsible for aldosterone or cortisol excess. The second important point is that these illicit regulatory mechanisms reflect a normal differentiation of the adrenal cells, neuroendocrine or gonadal-like differentiation. They are favored by the underlying genetic defects. So there's clearly a link between the genetic defects that cause the disease and the formation of these illicit paracrine mechanisms. And finally, they represent valuable potential targets for new pharmacological treatments of corticosteroid excess. For example, tryptophan hydroxylase inhibitors may be of great interest in patients with Cushing syndrome overexpressing 5-HT receptors, and ACTH receptor antagonists could be used to treat hypercortisolism in patients with macronodular adrenal hyperplasias. Thank you for your attention.